Hello, everybody. Welcome to Disability Innovation Live. Thank you so much for joining us from all around the world. We can see you all starting to enter and join the call, so it's fantastic to have you with us today. The session today is going to be looking at mobile as AT and exploring community health literacy. Let's see if I can get that read correct. Just wanted to do a little bit of an introduction to Disability Innovation Live. So my name is Louise Gebbit and I am Head of Comms and Engagement for the Global Disability Innovation Hub. And our Disability Innovation Live series is really an opportunity for us to create a bit of an informal space so we can share some knowledge, ideas and reflections. It's a bit of an opportunity to hear a bit more about some specific projects and areas of research, and also to hear about the stories behind the innovations and the people behind the products, and a space for discussions and questions and debate. So it's quite an informal session. It's a real opportunity just to hear a little bit more around some particular areas of our programs, and also to ask questions. So we asked for the questions to come through the Q&A box. That will allow you all to see the other questions that people have asked, but it also means that we can then come to them and answer them through the session, and also potentially afterwards as well if there's any additional we maybe don't get to during the session. So please do use the Q&A box. The chat box we'll use to let you know any particular details or links as we go through the session, if there's ever anything of interest that we'd like to share as panelists. And you as attendees can also use the chat box if you have any queries or questions you want to send to us directly, but it is turned off for everybody to see across the webinar, just because sometimes screen readers will read out the chat function, so that's better placed for the general questions and conversations within the Q&A box. There are closed captions available today, so please just use the button on your screen, which is usually based for using a laptop, at the bottom of the screen to turn on closed captions if you're interested in viewing those. So today we're going to be hearing from the Global Disability Innovation Hub, the Development Planning Unit, who are both based at UCL, University College London, and the SHM Foundation, and we'll be showcasing work from the Global Disability Innovation Hub's 80-20-30 programme funded by UK Aid, and also I'm hearing a bit about some of the work contributed by the Sierra Leone Urban Research Centre. So I'm going to hand across now to Professor Kathy Holloway. Kathy, I shall leave you to introduce yourself and tell us a bit more about yourself.
Thanks, Louise. Hi, I'm Kathy Holloway. I'm the Academic Director of the Global Disability Innovation Hub and a co-founder of GDI Hub, and it's great to have you all here today. Thank you for taking the time to hear this fantastic work that happened in Sierra Leone, led by the Development Planning Unit here at UCL. And so, what is GDI Hub? Just for those of you that don't know, we're an academic and research practice centre accelerating disability innovation for a fairer world. We're based at the UCL East campus, that's in the east of London, and it's that campus is a legacy of the 2012 Paralympic Games. So UCL makes up part of what's called the Cultural and Educational District, and we are joined by colleagues and friends from, for example, University of the Arts London and Loughborough University in trying to create a new centre of disability innovation, continuation, Paralympic legacy fun. GDI Hub works in 60 countries with over 70 partners. We have reached 34 million people, which still, I must admit, surprises me every day since we started in 2018. How do we do this? Well, we do this across different areas of work. The first being research, so that is to be expected, being based in academic centres. So we create knowledge and we also create solutions. In terms of innovation work, that has to date been clustered around growing inclusive ecosystems of innovation. And we also run programmes. So our major flagship programme is the 80-20-30 programme funded by UK Aid, which has funded this package of work you're going to hear about today. We teach, we've got a great master's programme in disability design and innovation, which you are very welcome to come and join us on. But we also have PhD programmes and do other forms of teaching, and we advocate. So we try to make sure that the evidence reaches as wide a possible audience as possible. That's not just so that we can preach, it's so that we can be critiqued and get better. So this is this programme today is part of that critique. So do ask questions, do probe. We do want to be able to explain what we do, but also to learn to be better for future programmes. Those things intersect with sort of different thematics. One of them being assistive and accessible technology, which is where what you're hearing about today fits. But we also do, under the 80-20-30 programme, for example, and other work, inclusive design of the built environment, inclusive education technology, climate and crisis resilience, which sometimes people are surprised that we do that. But if you imagine that the majority of disabled people or persons with disability live in no resource settings, and so the majority, 80% of people with disabilities, are living in the global south, or global south is probably the best politically correct term for the area. That's also the area where climate crisis, is most affected. So we have this problem where the poorest countries and the poorest communities and the poorest countries have the highest number of disabled people trying to tackle one of the world's biggest problems, being the climate crisis. We also look to use cultural moments like the Paralympics and like other cultural events to aid spikes in participation of disabled people within society. And finally, we do all of this through partnerships and collaborations. So 80-20-30 is a programme of testing what works to improve life-changing assistive technology for all. It's currently a £40 million programme funded by UK Aid, and that money has been 100% matched through partner funding. We explore and test innovative ways to address systematic challenges and get AT to the people who need it worldwide. And alongside global partners, we've powered 40 novel assistive technologies, supported 52 startups, and tested 10 innovative service delivery models with the most promising African AT ventures. We've also answered 20 key research questions and published over 200 research papers. Many of those papers supported the first global report on assistive technology, which was published just over a year ago. We divide the 80-20-30 programme into 4 clusters: data, evidence and impact, improving data and evidence to unlock investment into AT, supporting innovations, that's both the ecosystem as well as new products and services to get service delivery models to scale. We support countries in implementing their policy. So even innovations, if they are great innovations, they're great products, they're great services, if there's not a market for them to be able to be absorbed into, there's no point in creating the innovation in the first place, because it still won't get to the people who need it. We need countries to be in a place where they have the foundations to make sure that there's system level ability to deliver assistive technology to all of their citizens. And some of that leads into market shaping. In the 4th cluster, we look at building capacity and participation, so community solutions to overcome stigma and promote inclusive design. And actually, the project that you're going to hear about today sits in cluster 4, building capacity and participation. What we're talking about today is this focus on characterising mobile phone inclusion among assistive technology users. And as I just said, that came out of the 4th cluster of work. But there are many bits of work within 80-20-30 which touch on the idea of mobile as assistive technology, or mobile as an unlocker to assistive technology or disability inclusion. In early 2019, we released a scoping paper, Mobile Phones as Assistive Technologies, the Gaps and Opportunities, and that was presented at the WHO and supported and was written, co-authored by GDI Hub and the GSMA. That was a precursor to GSMA launching their first Understanding the Mobile Disability Gap. That 2019 report was funded by UK Aid via the 80-20-30 programme, and since then GSMA have continued to use the same methodology to monitor that gap over subsequent years. This also led to a couple of academic papers where we looked at bridging the divide, exploring the use of digital and physical technologies to aid mobility for mobility impaired people living in informal settlement, and also looked at the impact of mobile technology on the lives of persons with disabilities in Kenya and Bangladesh. The second paper is actually just an academic paper of the GSMA report. The first paper is a paper which was in Canberra, where we began to explore whether or not a mobile phone could act as an assistive technology when the physical infrastructure was too challenging for a wheelchair user to actually be able to leave their home. Today, I won't talk too much about it because the team will be discussing it. It looks at exactly what happened in this project in Sierra Leone. And currently we have gone on to fund a project in 3 countries, Kenya, India and Brazil, which is a third funded by 80-20-30, a third funded by Google and a third funded by At Scale, which looks at mobile phones as an assistive technology, really testing that hypothesis with about 1,500 people globally, half of whom have hearing impairments and half of whom have a visual impairment. And so with that, I think it's my turn to hand over to the main attraction of the day, and I will apologise in advance for leaving early, but I am due to lecture in about 5 minutes at another part of campus. So we'll catch up on the recording. Over to you, Julian, and thank you so much for being here today.
Thanks very much for the introduction, Kathy, and I'm really pleased to be here today. My name is Julian Walker. I'm Professor of Inclusive Social Policy at the Development Planning Unit, which is a department in University College London. And as Kathy said, we were part of the 80-20-30 programme. I'm just going to wait now. Rini, are you able to share your screen? Otherwise, I can share mine.
Yes, I'll just do that, Julian.
Okay, thank you. So I'm just going to talk a bit at the beginning about the research project that fell within the wider 80-20-30 programme, which is the project that the mobile phone intervention that we're going to be talking about today came out of. So I wanted to give you a bit of context and background on that first. So I'll just wait for the slides. Here we are. Great. So the session today is looking at mobile as an assistive technology and looking particularly at mobile phones as a tool for community health literacy. So this came out of an intervention which was part of the wider 80-20-30 programme that Kathy's just been talking about. And it was sub-programme 9 within that, looking at community-led solutions at ATs in informal settlements. So actually looking at self-built settlements of the poor in the global south. And the focus of our project was exploring what assistive technology means to users in low resource settings. And specifically, we were looking at the experiences of AT users in informal settlements, why they're using ATs, and some of the supporting community responses to help them do the things that are important to them with ATs. So this worked through 2 phases. First of all, mapping out this existing context, and secondly, developing an intervention in order to support the aspirations they're working on. In parallel, we had a study on access to assistive technologies through informal markets, because one of the things that became very clear straight away is that actually the majority of the residents we were working with were accessing their AT through informal markets. So one of the first things we did was use the RATA survey, which is the Rapid Assistive Technology Assessment Survey, which has been developed by the World Health Organization to look at existing need for and access to assistive technology across populations. So we did this in the settlements we were working with. And one of the things we found out straight away is actually the majority of people were getting their assistive technology from the informal sector, which meant often secondhand producers or locally produced unregistered businesses making assistive technology. And actually, based on that, we did a study to actually understand what are the implications of informal markets for the production of assistive technology, and to what extent are they positive or negative. And I've just put a reference here for a paper that I did with Emma Tebbett from the World Health Organization with some reflections on that in case people are interested. One of the things that came up very clearly through this informal market study was the importance of mobile phones as a de facto assistive technology for many of the people we were working with in the 4 settlements we were looking at. Okay, so the settlements we were looking at were 2 informal settlements in the city of Banjarmasin in Indonesia, which is in South Kalimantan province. And as you can see from the photo, it's known as the city of 1,000 rivers, and most of the houses are built on stilts, which has particular issues around accessibility and disability. The other 2 settlements, which will be the subject of what we're talking about today, were in Freetown, the capital of Sierra Leone. And we were working in 2 informal settlements there, one coastal informal settlement called Thompson Bay, and another one up in the mountains called Dwarzap. Next slide, please. Okay, so the project approach for this sub-project was working through 2 phases. In the first phase, we wanted to map out the aspirations and community-led interventions for AT users in their communities. So we were working, as I said, in 4 informal settlements in 2 cities, Freetown and Banjarmasin. We started by exploring aspirations for better life outcomes shared by residents with disabilities and some non-disabled residents, and the role of assistive technology and community actions in realizing these. And we use this as a basis for the second phase, which we'll be talking about today, in which we co-produced and trialed 80 interventions in the 4 communities. So based on the aspirations, the collective aspirations, which we found in the phase 1 mapping, to test relevant AT co-production approaches, drawing on both community resources and inputs from the wider AT project team. So the co-production we're going to talk about today was a community health intervention, which was raised as an important aspiration using mobile phones. So in terms of mapping the aspirations, the first phase, to give a bit of background on how we did that and set the context of the intervention, we started by doing a census in the 4 communities using the RATA tool, the WHO Rapid Assistive Technology Assessment tool that I talked about in the 4 communities to get a sense of disability prevalence, but also AT need and existing access to assistive technologies. Based on this, we then defined the research participants. So actually we had a core group of research participants to do this mapping with, of around 30 people in each community, of whom 50% were disabled participations, another 25% were AT users who maybe didn't define as disabled, so particularly, for example, older persons, and the remaining 25% were non-disabled residents, just ordinary residents of the community. So we worked with them, doing a participatory workshop and a series of participatory photography tools that I'll talk about in a second, to identify 2 valued functionings or aspirations across those groups that they wanted to work on mapping out. And these could be collective ones, so the ones that the most people had in common and were collectively important across the disabled and non-disabled participants, but also in each case a transformative one, so one that might be particular to a particular group, but we felt, or they felt, would have the biggest change in their lives. So when we selected those 2 aspirations or functionings, we then mapped out actually what were people doing to try and achieve them and what role did assistive technology play in that, and then had an analysis workshop. And this led into phase 2, which was the co-production. Next slide, please. So some of the tools we used to map out the aspiration were, for example, participatory photography. So one of the things we did is a tool called Photo Voice, where all the 30 participants went out and took photos of things that were aspirations in their lives that were important to them and things that helped them to achieve those aspirations and blocked them. Based on that, we then did a series of participatory workshops and gallery walks in which the groups in each community collectively decided the aspirations they wanted to work on. So one that linked them all together, and one, as I said before, that they felt would be the most transformative for a specific subgroup of the group. Then in terms of mapping out how they were able to achieve them, we then did a series of photo essays where a photographer shadowed some of the participants to actually understand what they were doing to meet the aspirations. So the photo here is one of our participants in Banjarmasin, and the aspiration he was looking at was community engagement, which was a collective one a lot of people focused on. He has a learning disability and is very keen on community engagement, and he does this through collective work in the mosque and the community in terms of cleaning, and he's very well known for this and actually very well regarded in the community as a result of his collective cleaning work. Next slide, please. So one of the things that was obviously important for us in relation to this was the accessibility of the research methods used. So as one of the key research methods was participatory photography and participatory workshops, one of the key issues was, for example, around hearing impaired people. So we provided sign language interpreters, but actually we found that a lot of participants with hearing impairment still withdrew because they couldn't understand the sign language. So a particular challenge we had was the fact that local sign language wasn't understood by many of our participants in informal settlements, and they developed their own sign language. So we had to find ways of including them through their carers who would interpret for them that had particular challenges around that. Interestingly, we were worried initially that photography wouldn't be a good approach to use for people with visual impairments, but actually with some changes in cooperation, that wasn't the case. So the bottom photo on the right was with FEDUP, which is the Federation for the Urban Poor community group in Freetown, and one of the members who has a visual impairment actually discussing the participants, a blind participant photographs with him, and actually even though the blind participant couldn't see the photographs, they were used as a prompt for discussions, and actually that worked quite well. Next slide, please. One of the other things that became really important for us through the research was that actually a lot of our research participants, due to a very high level of stigma in the communities we're working with around disability and some particular disabilities, had been quite isolated and hadn't self-declared as disabled people or engaged with other disabled people. So actually, the research became a really important entry point for disability activism in informal settlements, both in terms of us working with disabled people's organizations and bringing them into the communities where they hadn't worked before, and also our participants beginning to act as a group and work together as an interest group, but also getting the organizations of FEDER, which is the Federation of the Urban Rural Poor, that's working on development rights for these informal settlements, to begin to work more with disabled members and activists as part of their wider settlement upgrading activities. And one of the ways that we did this was to use the research project and the findings of the research as a platform for the International Day of Persons with Disabilities celebration. So actually, the communities had never had celebrations or actions for that. So in the two communities we were working, we used the launch of the research findings as a disability celebration day in the two communities. And actually, this linkage was the focus of a PhD research project by Vicky Austin, who now works at the GDI Hub, which was looking at how does access to assistive technology mediate recourse to disability justice for urban poor people. So actually looking at the politicization of actions and how AT works in that. And actually the emphasis on the sort of disability rights activism came very much through that PhD research. So the final selected aspiration in the two communities in Freetown, Dwazark and Thompson Bay, was the collective aspiration they wanted to work on was affordable and accessible healthcare. And this became the basis for the co-production intervention for AT that we decided to work on in those two communities. And as a result, we invited in the organization SHM Foundation, which has a very long history of working with mobile phones as a resource for community activism around particular issues. So I'd like to hand over at this point to the team from SHM Foundation to talk a bit about how they used mobile phones as an AT around this community aspiration of affordable and accessible healthcare.
Thank you, Julian, for that lovely introduction of our work. Good afternoon, everyone. My name is Rini Sinha, and I'm the head of strategy and creative at the SHM Foundation. As Julian just mentioned, our mission is to support people and communities in developing solutions to the challenges they face in ways that work for them. And some of the areas that we work in include mental health and well-being, education and livelihood, and access to the arts. We have nearly 2 decades of experience in participatory co-design of mobile phone-based groups for socially isolated and stigmatized population groups in ways that work from them. We are very proud to have been a part of this project where we got an opportunity to adapt our model to gauge the nuances of how mobile phones can be leveraged to provide access to health information for people living with disabilities. And all of this was conducted remotely because COVID was at its peak during this time. So I mean, when it comes to mobile phones and ICTs, their correlation when it comes to influencing development outcomes and how they are a very integral part of our day-to-day lives is something that we all know about. However, when it comes to people living with disabilities, there's definitely a crucial role in bridging the accessibility gap that they might face in terms of accessing both services and resources. So mobile phones and ICTs do have the potential to bridge this gap. Almost act as enablers when it comes to supporting people. But on the basis of our experience, we knew that it is not a universal digital experience that everyone has. And we really wanted to understand the nuances and day-to-day experiences of people using assistive technologies and mobile phone groups. So before launching into the pilot, we decided to embark on a quantitative study of 112 participants. Both in informal settlements of Indonesia and Sierra Leone. The objective was, as is mentioned on the slide, to understand the day-to-day attitudes, use of ICTs, behaviors, and what are their perceptions when it comes to using mobile phones. And some of the top findings, which also laid the foundation of the pilot that we eventually designed, were that, of course, regular mobile phone use was very widespread across both countries for many different purposes. People with disabilities did have lower access to mobile phones, but what was interesting was disability was not the singular factor affecting it. It was more to do with the infrastructural reasons, such as costs related to use of mobile phones and other technological literacy and other demographic factors. Interestingly, mobile phones were used individually in some cases, but also used collectively, especially when it came to borrowing phones from neighbors or other family members. So based on this quantitative study, this laid the foundation for designing the virtual mobile phone-based support group. So what came out of it and what played a very key role in designing the groups were some of these factors. We understood very clearly that these groups need to be run by people led with disabilities in order for them to be true to what their needs are. It has to be community oriented. There need to be questions from the communities related to health information that we need to incorporate into these into the facilitation of these groups. The information has to be simple and accessible. It didn't have to be very heavy that way. And of course, it was very important to create a safe virtual space. So our safeguarding measures had to be very rigorous when it came to designing these groups. I will now introduce the pilot. Sorry, missed a slide there. The pilot wherein we decided to launch in 2021 a 5-week intervention, which was a collaboration between DPU, SLUG, FEDERP, and the SHM Foundation in the informal settlements of Dwozak and Thompson Bay in Sierra Leone. The focus of this project responded to the priority which Julian mentioned earlier about as a shared aspiration, which was affordable and accessible healthcare. So before launching into what exactly the model was, I would just like to give 2 minutes to probably build a little bit of context. The first piece of context would be generally about health literacy and how it unfolds when it comes to people living with disabilities. So health literacy is regarded as critical in managing personal and community health. When it comes to people with disabilities, they face barriers that make it harder for them to access both health services and build health literacy, particularly in low resource settings. So some of the barriers that they encounter may be attitudinal. It might be discrimination from healthcare settings or healthcare providers. These might be physical barriers, for example, inaccessible entrances. There might be communication barriers, for example, lack of sign language interpreters, or just information not being accessible in terms of the way in which it is expressed or articulated. So these barriers can make it really difficult for people with disabilities to access accurate health information and then in turn build health literacy and take care of their health. So through this project, the main objective was to explore the potential of mobile phones in enabling people with disabilities to access that health information. A little bit of specific context about both these two settlements. So approximately 1 in 5 residents in both these settlements have a disability and generally a low accessibility to assistive technology products. Both settlements have a single healthcare center, again with the primary focus on maternal and antenatal health, again compounding challenges for people living with disabilities when it comes to accessing healthcare services. So now on to the model and the intervention. As you can see, the main objective was to provide a platform for people with disabilities, carers, or AT users to access health information on topics that were important to them and also disseminate it within their communities. Now, how did this model operate? I think in one sentence, the best way to sum it up would be to imagine almost like a WhatsApp group. But of course, the differences in how this virtual support group was set up is something that my colleague Desmond is going to share in detail. But in terms of the model, there were 16 health champions or people with disabilities who received a mobile phone training in how to use it, and their mobile phones loaded with data packs as a part of the project. There were 4 facilitators who also received mobile phones who would serve as the facilitators of these 2 groups. We used the digital platform called Rocket Chat, where all of these exchanges and communication was happening. As I said, this was a 5-week-long project, so there were weekly topics that were decided, that were discussed. There were guest speaker sessions, which we'll share with you shortly, and how the engagement was there. But essentially, in guest speaker sessions, we had doctors from the community within Sierra Leone come on board to answer questions that the community had. And there were other modes of disseminating information, such as group discussions, printed posters, and the rest. I will now hand it over to my colleague Desmond, who was the tech lead on the project, to share more about his experience and how he went about doing all of this virtually. Over to you, Desmond.
We'll just try and get Desmond set up. Desmond, if you can have a go at turning off your camera and your turning on your sound, and we'll see if we can get you live. We did test Desmond before we started, and it was all up and working, but he may be having a challenge with the internet. So we'll just give it enough time, more seconds. Oh, I can see some action. Are you there, Desmond?
On that, my network was acting up a bit. Sorry, can you guys hear me?
We can hear you loud and clear. We haven't got any video, but we can certainly hear you. So please do continue. Oh, we may have lost Desmond again.
Am I audible?
You are now. Yes, you've come back again. Have another go.
All right, thank you. Sorry about that. So yeah, my name is Desmond Tau. As I've been introduced before, my name is Desmond Tau. I'm a tech supervisor for the SHM Foundation, working under the Kuluma project. Please confirm that you can still hear me.
We can hear you, Desmond. The line is cutting out a little bit, but it's still audible, and we're able to capture you and hear you and have the captions working. So I'll hand back across to you to continue, but if it keeps jumping out too much, we will let you know. But at the moment, I think we're good to continue. So I'll hand back across to you to continue, Desmond.
Okay, yes, thank you. As I've said, my name is Desmond Tau, and I'm a tech supervisor for the SHM Foundation, and I work under the Kuluma project. So what my role is that I oversee the operations of the tech used to run these kind of support groups, whereby young people, or in this case, people living with disabilities, get together and discuss issues that they may come across as people with living with the condition. So basically, is that I think Rini has mentioned before that they were using Rocket Chat. So some of you might have a question as to what Rocket Chat is. So Rocket Chat is a digital space used by the SHM Foundation and the Kuluma project to run psychosocial support groups. So it was also adapted by other projects such as the YMM in Zimbabwe, which is Young Mentor Moms, and also used again on running the 80-20-30 support groups. So how it works is that more like WhatsApp, it's basically just WhatsApp, just that it's much safer in terms of the anonymity of the groups, because people who use the groups don't want to be they don't like being their identity being shown to the world. So what they do is that we would create usernames for them. So meaning that the platform doesn't require you to have to put in your any personal information or even your cell phone numbers. So whatever it is that you be, whatever name that you have chosen for yourself to use in the groups will be your nickname. So yeah, basically that's that. And Rocket Chat also, as I've said, it works just like WhatsApp. So it means that you will receive and send out text in real time. So meaning that anything that you're communicating, never mind where you are around the world, anyone can receive it at the same time as you just sent it. So yeah, can you guys still hear me?
Yes, thank you. We have you loud and clear. Do continue.
All right, thank you. Yes. So as they've been speaking about the engagement and some of the code designs, and I think having to have worked with the team, with the 80-20-30 team, it has been great because I got to work with really hardworking people, and it was quite an experience, more especially because of the time that was the time that we're in, because it was, I think, during COVID, and it was a hard time for everyone. So we were all isolated and working indoors. So having to set up the devices for them remotely was not, it was quite a challenge, but also not quite a challenge because of the team that was behind this whole thing, and which is our and her 80-20-30 team. So they did a pretty good job, because I remember we would have very long hours of Zoom meetings trying to make sure that everything is set up correctly and it's running as good as it should be. So yeah, it was quite an interesting journey and an interesting thing to do at that time. And I think for me, the groups came in a time of need. They came in a time of need whereby everyone was isolated due to COVID and the coronavirus restrictions. And having the groups run at that time helped a lot of participants, myself included, as much as I wasn't a participant at that time, but I was part of the team and I was working in the background. But I think at that time, I also used the groups to my benefit, if I may say. So I used the groups to my benefit in terms of I would also join in the conversation and just read into what they are talking about and some of the challenges that they come across. And I remember there were times whereby someone would ask about things like, how do you or what are home remedies that we can use in order for us to prevent COVID? And I think I used some of those tips for myself also. So yeah, it was quite an experience and quite an interesting thing to experience at that time. So yeah, it has been. And also I think the reason that makes this group stand out from the rest is the engagement that was happening at that time, because as I said before, it came in a time of need. So everyone was just indoors and you needed something to just get your mind off of the situation that we are currently in around the world, because it wasn't only us in South Africa or the people in Sierra Leone, but it was all over the world. So meaning that everyone needed help at some point. So I think it was a distraction to everyone, not as much as it was a distraction, but it was also quite a good thing to happen at that time, because it was informative and people used that platform to get their thoughts across and be able to communicate with other people and understand things from a different perspective. So, and the engagement was quite good, because the 80-20-30 was one of the best groups I've ever monitored before. And over the years, because I think I've been part of quite a lot of groups before, and what I experienced at this time was quite different from what I'm used to. So because one thing I've noticed was that they had quite a good friendship altogether. Not only the participants, but also the facilitators who were running the groups. They were all hands on in terms of making sure that everyone is up to date with what's happening with the next topic of the day and what's expected of them to do on that day. So everyone was just hands on in terms of that. And I remember while the groups were being closed, I think we were doing analysis with the team, and we were going through over, I think, about 5,000 messages that were sent in that period of time, to kind of show that number showed us that everyone, I think, the people who were in those groups at that time really needed the space and really needed the platform to happen at that time. So it was quite good to have those groups at that time. And we had about, I think, 200 questions asked over that period. And it was quite good, because most of them were actually enjoying the GSL. If I haven't mentioned before, the GSL is the guest speaker lounge, whereby I would invite people from other professionals, let's say other professionals, people like your social worker, your psychologist, your doctors, and you name it. So they were all invited in those groups on a weekly basis, I think, because yeah, it was on a weekly basis. I think it was every Friday, whereby we had a guest speaker lounge, and everyone was well engaged, and everyone was asking questions, because I remember we had about 215 questions asked in the GSL, and an average of 190 messages were sent per guest speaker lounge session. So which showed that everyone was well engaged and everyone was enjoying the sessions at that time. And also, we had about 40% messages sent over the counted five weeks intervention. So yeah, it was quite a journey for me, and I think the rest of the team would also agree that having those group run at that time also gave us something to talk about as a team. Sometimes I remember we would have our weekly calls and would somehow debrief and discuss everything that happened over the week in terms of the groups. And for me, I had nothing bad to say. It was always great, and for some reason, I totally enjoyed the groups at that time. So yeah. At 2030, the messages, as I've said, the messages were 5,000 plus, and with about 200 with around 215 questions asked during that time, at the time of the interventions. And we had about, let me get my numbers correct, I think we had about 112 or 110 participants at that time. So it was quite a good thing. So yeah, I think that's it on my side, Rini. I don't know if I may have missed anything.
Not at all, Desmond. Thank you so much for literally refreshing memories for all of us of setting up the group. Hopefully that has helped everyone in this webinar understand a bit more in depth about how the groups function and what all was happening. So yeah, just to add on further to what Desmond said, there was massive engagement that we witnessed on the groups. And I think one of the key features when we are running these support groups in whichever context it's is that we are always listening to what is happening on the group and what are the needs. And on the basis of that, I think the facilitators and health champions express the desire to almost have a reference to everything that was discussed in the groups. So on the right, as you see, there's a poster where we based on the answers that the doctor gave, we compiled all that information and created these posters, which were eventually printed by the implementation partners, huge Redis to Slurk and Fed Up on ground, and were actually distributed to health champions. So that was another way to ensure that the information was transmitted to the communities, that almost kind of cascading learning was happening via the health champions to the community. So when it comes to creating and running these groups, it's very important to keep listening, keep adapting, keep innovating to understand what is the best way to support the needs of the group. Some of the insights and learnings from the pilot, even though it was a very short one, of course, there was a lot of exchange of information and knowledge which we got to know through the pre-intervention and post-intervention surveys that health champions found very useful. Some quotes out there to highlight the role the group played. There was also that sense of connection and support which the health champions felt, which also was a major role that we've noticed groups like these play in terms of building that social connection, social support, when people have experienced have shared common experiences in life. Highlighted by one of the quotes here, the chance it gives to disabled people to participate, it has helped us to take the lead, to feel belong, and it brings inclusiveness to people with disabilities. There was also that sense of cascading learning. So health champions reported to us that they were proud to share these learnings in the community, be it with neighbors, family members, etc. And there was, of course, building the digital literacy skills when it came to using the mobile phone and the tech training that it was accompanied with. So of course, there were a few challenges also as well. It's not there isn't a slide here, but to quickly run you through some of the challenges. Of course, due to internet connectivity issues, there were sometimes challenges around connection, and be it when it came to the guest speaker joining in, or even when it came to running the groups otherwise. So there was that infrastructural hurdle that we often faced. I think initially it was also in terms of setting expectations of what the role of health champions is, which is mainly to share information and probably not provide access to critical services. So those were a few challenges that we encountered. A good challenge actually that we faced was that during the guest speaker sessions, there were so many questions pouring in that we couldn't, it was impossible to answer all of those. So we later requested the doctor to share that information regardless, and hopefully present it in the form of those posters that we showcased earlier. In terms of learnings and future work, of course, huge learnings for us at the foundation, because this is a different population group that we worked with in new contexts. And different needs. So definitely all those learnings feeding into all our mobile phone based models coming up as we continue our work. And of course, the challenges for replication and scaling up, of course, we realize that there's huge potential and also appetite when it comes to using mobile phones and ICTs in terms of improving development outcomes for people with disabilities. But probably the challenges were more institutional and infrastructural, maybe related to internet connectivity, also barriers such as accessing a phone, loading a phone with data pack, all of those. And we definitely felt that there's a potential to embed this kind of a pilot within the community health workers system in Sierra Leone, which is working towards improving primary healthcare services. So those are some of the learnings and potential for future work that we thought was with the pilot. But of course, over to Julian and Anna, director at the SHM Foundation, if you have any further thoughts to share.
No, thanks, Rini. That was very clear. So I think the sort of final takeaway, as Rini's just saying, from our perspective, is that the use of mobile phones definitely served a really important function for health access, but also around mobilization of our disabled participants and their engagement in community activisms at this very critical time of COVID, where people were particularly isolated. But the real challenge is not the mobile phone as a piece of technology, it's the institutional basis to support that. So actually, the groups that they had very much needed things like moderation to make sure that people were protected and safe, that people got access to data, and also that they linked to the community health worker system, which actually in the country is working on health access very much in rural areas, not looking at informal settlements in cities, and not with a particular consideration of the needs of disabled health users. So I think the takeaway is very much the technical solutions of mobile phones are there. The tricky challenge is the institutional spaces to support the application of that. I don't know if Anna had anything to add.
No, I don't really, except for the fact that I think the other thing that was very interesting about this model was having a doctor and a medic involved in the group. And she was absolutely amazing at responding to messages. It's a real talent that we found, that some can do that incredibly well, and some find that very challenging. And in this particular group, she was very good at doing that and understanding how to kind of communicate that way. So anyway, that was just another insight, I think, from this work. But that's all I have to say.
Wonderful. Thank you so much, everyone, for all your presentations and the sharing of all that work. I think it's a lot of food for thought there, and lots of detail around the process that was involved, and the reflections and the learnings that came from the project. So if anyone in the audience has any questions, please do feel free to pop them in the Q&A box and we can ask them. We had a few that came through before the session as well, and I think quite a few of them have been answered as we've been doing the discussion. But I know there was some questions and some queries really around that. I guess that wider picture around, obviously we talked a bit about the kind of access and the availability of mobile phones and that sharing of the mobile phones within communities. So I guess, how did you find it from a kind of reporting and analysis perspective to really understand the gap, I guess, between the information being provided to mobile phones and how individuals are able to access that information, and how clear and detailed you can be in terms of the visibility that was coming through from the information being shared, and how kind of, I guess, how sure that you can be that when that messages and those key messages were being put out there, they were reaching the people you'd anticipated them reaching, if there was that sharing of the mobile phone devices happening between individuals and potentially between communities as well. I haven't pointed that to anyone, have I? You all look a little bit sheepish. Would anyone like to take that question? Really, I can see that you've taken your microphone off, which is a brave move. So we'll come to you first, and then if you wish to throw any of your other colleagues under the bus to also answer it, please do nominate somebody else. I shall come to you though.
Thanks, Louise. I think there are two parts from what I understood to your question. The first part about the sharing of mobile phones, which was a finding from the quantitative survey that we did. So that is one, to answer the first part of your question. When it came to particularly this pilot, within the project, individual mobile phones were given to the health champions. So we really couldn't assess what the implications were when it came to ownership of mobile phones and how information was disseminated in that context. This is what I understood. For Julian and Anna, Des, if you would like to jump in as well.
Yeah, I think from the study that SHM did, and also from the informal market study, what was clear is actually in Indonesia, where we didn't do a mobile phone-based intervention, actually there was much wider use of mobile phones. In Sierra Leone, there was fewer people had access to them. There were more shared phones, but also the type of mobile phone people had were much more basic. They weren't smartphones. So actually that's why we made the decision in the intervention to buy very basic smartphones for the community health champions who were all disabled people. So recognizing, because they were normally sharing, if we had the phone for them, they'd be the sort of chief person using it, to sort of try and disrupt the hierarchies in how phones were being shared. But again, if we think about scaling up a process like this, that will come across the challenge of who has access to mobile phones in society and how they're shared. So yeah, it's an ongoing problem.
Yeah, that's really interesting to hear a bit more of those reflections. We have a couple more questions now that have come through the Q&A box from audience members. So we'll have a look at the first one. So the first one is, how do you address the issues around internet/network access in order to use mobile phones most effectively? So I don't know whether Anna, you want to start off with this question, or Julie, if you want to pick this one up.
I think Desmond's our guy.
Ah, Desmond, of course. Yes, the technical expert, absolutely. Desmond, should we have a quick go and see how your connectivity is doing right now?
Sorry, I missed that. Yeah, you were breaking a bit. So what was the question again?
Yeah, no problem. So the question was, how do you address the issues around internet and network access in order to ensure that mobile phones are used effectively?
Oh, okay, yeah. Okay, thank you. I think what we did as with the team, with the 80-20-30 team, was that whenever there was problems in terms of network and the usage of internet, we would actually try and troubleshoot, whereby we would I would ask them to call the participant and ask them about the network coverage in their area, and just making sure that they're in a space whereby they can move around and be able to get the network access that they're looking for. And yeah, so that's basically what we would actually do. We would just have a call. They would simply just text me on WhatsApp and say, no, we're having a problem with so and so in terms of network coverage, and their messages seems not to be we seem not to receive any messages from them. So what can we do? And what I would advise for them is what I just said now, whereby I would ask them to tell them to just move to a better location whereby there's maybe a good network, because of the SIM cards that they are using, I'm not familiar with, so I wouldn't know which area was best for a better network coverage. But yeah, I think the credit goes to the team, the 80-20 team, because they were working tirelessly in terms of making sure that everyone is connected and their mobile data were all loaded up in time. So yeah, I don't know if that answers the question.
Yeah, absolutely. Thank you so much, Desmond. And we've got a kind of follow-up question to that actually, for you, which is possibly a really hard question to answer, but maybe you could just give us a bit of an indication. And someone asked kind of what are the kind of costs of smartphones in low middle income countries. So I don't know whether you're able to just give us a bit of a feel for, I guess, how accessible they are for people to buy and purchase, and if those costs are quite stable, or if you're seeing quite a change within these markets. So is that changing over time in terms of people's ability to access smartphones, and what is that currently looking like?
So in terms of the accessibility of purchasing or the usage of a smartphone, I think, and the costing also. In terms of costing, I don't quite remember the costing very well, because I think it was a while back, but each device, I think it costed, I think, about 80, is it $80 somewhere there? $82. So yeah, and also accessibility. In terms of accessibility, we had to get in touch with the manufacturers, some of the manufacturers and distributors of the devices, because we were actually buying a whole lot of devices at the same time. So that's where the problem was. So that's where the challenge was, whereby we couldn't just walk into a store that sells devices and say we want 80 or 100 phones at the same time and get them at the same time. So we had to make sure that the team goes out and tries and source out a distributor or someone who was going to find the phones for us, and then lets us know so that we can send in someone to collect and purchase the devices from them.
That's great. Thank you so much for sharing that, Desmond. So I realise we're coming towards the end of the session now. Just got a few minutes left. So what I might do is I might just pop around the panel and just see if anyone's got any final reflections they'd like to share, or any thoughts or contributions in terms of, I guess, kind of next steps or areas of particular interest that you are working on to kind of move this forward in other areas of your work, or things that you might feel are a real priority in terms of this kind of health, kind of access to health information and the mobile phone question, and how we kind of continue to move forward in this space. So Anna, you're first on my screen, so I shall come to you first, if that's okay.
Okay, thank you. Well, for us, it's as Rini said, it was a very exciting area for us to work in, because we mostly focus more on specific health conditions. I think we would love to send you, or hopefully you can get the links to both the reports that we produced. The first one, where we really looked at people's relationship to the mobile phone, I think is actually one we would love to kind of share more and look at how could it be applicable for other organizations who want to use mobile phones in their work. We really kind of looked into the different personality types, the kind of things that they need access to or support on, which I think sometimes we tend to jump into and just hand over tech perhaps without doing that piece of work before. So I think that's something that's a takeaway for us that we would love to share with others who want to work in this space. Yeah, is there anything else that Rini you want to add, or?
I think, Anna, just adding on to your point, I think in our experience, we've always seen that with these groups, it's important to keep them tailored in smaller numbers and more customized, in order to really understand the needs of people, their aspirations, and what is it that they really require. And sometimes with mobile phones, the tendency is to universalize the experience. So it's important that one understands the nuances, be it the context, be it the population group that you're working with, which is why it's important to keep these groups customized, tailored, and smaller. And I think that is what we need to continue doing, because it's the conversation, of course, scaling up and replication is important, but in a very nuanced fashion, which is what we learned ourselves, and also hope to continue doing in our some of our ongoing projects as well.
Wonderful, thank you so much. And Desmond, we'll come to you for the last minute. Just if you've got any reflections yourself from the project, or any final words before we wrap
up. Any reflections? For me, I don't think I have anything. I think I've shared my reflections in terms of how the groups went, and I think what I got out of the groups also was a highlight for me in terms of what I got out from those set of groups. And as Rini has said now, that the groups were tailored to the needs of the people that we were working with at that time. So we always try and make sure that everything that we do, we make sure that we cover such bases whereby we make sure that everything that we do is tailored for the needs of the people who will be using the space. And that, I think that's our strongest point in terms of having people being able to enjoy the groups, because they can relate to what's going on at that time, and also keeping the groups smaller so that you know who's who in terms of when you're communicating, and you would know if I'm in a group of 5, I know that there's Rini, there's Anna, there's so and so, and there's so and so, so that if I was to try and express something, I can easily say to someone and say, Anna, I have a question. Last time you said you were battling with 1, 2, 3. Well, how did you deal with that? Because I'm battling with that at this moment. So can you try and assist? So I think those were some of the things that came to mind now as you were asking the question. So yeah.
Thank you. And I think really interesting, obviously fascinating to hear about, I guess, the additional element, and I'm sure wasn't involved in terms of the planning of this project, of it coming very much at that time of COVID as well. So the environment was very different, I'd imagine, to the environment you'd have anticipated walking into. And then I guess almost just really increasing and highlighting the value and the importance of kind of digital communication and this kind of technologies for enabling those community conversations, and enabling people that maybe were already isolated, but very likely and very often within COVID became more isolated within these communities, the opportunity to continue to have those conversations and those engagements and access that's really critical health information. So really interesting just to hear all those reflections. Unfortunately, Julian has had to run off because he's lecturing, so he's had to run to his next lecture theatre, so isn't able to provide a final reflection for us today. But thank you so much for everyone for joining us and hearing more about the project. Thank you for the presenters and also the captioner, who's done a brilliant job of keeping up with us all today. And you can find all the reports on the 80/20/30 website, and I'm sure they'll also be on the organisation's websites as well that you hear mentioned today. If you have any questions, please do feel free to get in contact, and thank you very much. We shall wrap up there for today. See you later, everybody.
And thank you, everyone.